So, as an introduction of the of this discussion, I will discuss with you a recent letter to the editor in Hematologica. But first of all, I would like to stress again what we have observed in the EU MDS registry, and that's the impact of the dose density of red blood cell transfusions on the progression-free survival in low-risk MDS. And what you see here is the analysis on more than 1,000 low-risk MDS patients, the impact of the dose density in units per month. And what you see here is that the impact on the log relative hazard of the progression-free survival, that already at a very low dosage between 0 and, of course, 0 is the starting point, and 1 unit per month over time, there's a very steep risk in the univariate analysis, also in the multivariate regressing model, and more clear after adjustment for treatment with ESA, iron chelation therapy, and lenalidomide. So this really shows that also patients who are receiving very low units of red blood cells, which according to the current criteria are not transfusion-dependent patients, and we already discussed this issue of number of units per 8 weeks, which is probably too short, as we agreed upon. So you can see that this has already an enormous impact. Next slide. So this is the letter by Zeitner and colleagues to the editor, which appeared a few weeks ago, but was already online at the end of last year. So this was a study which had the title Time Without Transfusion Reliance. Reliance is almost the same as the transfusion dependency. And a novel patient-centric metric for new therapies in myelodysplastic syndromes. So they used this analysis of time without transfusion reliance, the so-called TWiTR period, which subtracts from the periods from the overall survival of each patient when the quality of life is assumed to have deteriorated. And these periods are the period when the patients experience disease progression, defined as relapse, and the period when patients are transfusion dependent. So this analysis results in 3 health states in patients treated in a certain study. The TWiTR state, which is defined as the time without transfusion dependence or transfusion reliance, or relapse. A transfusion dependent state and a relapse state. So the TWiTR state is the state without transfusion dependence and relapse rate. Next slide. So this was checked in a small study. The study most of you know, this is the pevodistat and azacitidine versus azacitidine, the P2001 study, which originally enrolled 120 patients. For this analysis, they analyzed 63 patients with high-risk MDS and a quality of life assessment at baseline before starting the treatment, and at least 1 post-baseline quality of life. So they didn't give the details of the quality of life assessments in that letter. The quality of life measures were associated with different clinical outcomes in both treatment arms, which means that an improved quality of life was seen in all patients experiencing a complete remission compared to baseline, and worse quality of life after transformation to AML. And the quality of life measures were similar in both treatment arms, so there was no difference. Next slide. So here you see the survival curves of the two arms, the azacitidine arm and the pevonidistat azacitidine arm. And you see three groups here. The orange group are the patients during the period when they have transfusion dependence. The orange group are the patients after relapse in the overall survival. And in the intermediate group, these are patients who did not receive transfusions according to the definitions of this study, and who have not relapsed. And what you see here is, first of all, the overall survival between the two arms, as you probably all know, is not significantly different. Also, but what you can see is that the transfusion-free survival period is significantly longer in the pevonidistat azacitidine arm compared to the control arm. Next slide. And here you have the numbers. So in the transfusion-dependent state, the duration was five months in the early stage compared to 5.3 months in the control arm. It's not different. The TWiTR stage, so the transfusion-free and relapse-free period, was 16 months in the pevonidistat arm compared to 11 months in the azacitidine arm. And this is significantly different, 5 months difference around. And in the relapse state, there is no real difference between the two arms. Next slide. So in the TWiTR analysis revealed that the high-risk MDS subpopulation of patients with the treatment arm had a significantly longer duration of this stage compared to the AZA arm, as just mentioned before. And the transfusion dependence duration was similar in both arms. The mean quality of life utility value was higher for the TWiTR arm compared to the two other stages, the transfusion dependent and the relapse stage. And this value was 0.82 in the TWiTR arm, compared to 0.77 in the two other arms. And this was significantly different. Next. Last slide. So they concluded that TWiTR analysis showed clearly that transfusion independence is a critical endpoint for improving quality of life of patients with high-risk MDS. And they also mentioned it will be interesting to apply the TWiTR analysis within prospective studies in lower-risk MDS patients, because that's probably more relevant population than the high-risk MDS patients, where the disease itself plays an enormous role. So transfusion independence and improved health-related quality of life may be the ultimate goals of these studies. So, and in addition, I just would like to raise the question, but for me it's not a question, but for many of you it is a question. Will acquired prolonged transfusion independence be associated with a better survival? That's many of us have this idea. So this is what I wanted to present with you and to show to you before we start this discussion. And the discussion is so the relation between transfusion independence and better survival and better quality of life. Thank you. So the discussion is open right now.
Theo, can I comment?
Please do.
Well, obviously, I'm not going to argue with this letter, which I have to admit I have not seen. The point that I'm trying to follow with what Mikkael and I think Rafa and others said, I think Ruben too, is what is really a good endpoint in these studies.
Mm-hmm.
And I know that the FDA prefers, what they call, and probably others are more experienced than I am, Mikkael and others, the FDA likes, a real benefit for the patient. And in the FDA eyes, hemoglobin or platelet count means nothing. They want to hear what is the need for transfusions of red blood cells or platelet count. It was the same with L-Thrombopag and Romiplastim data in those days. But on the other hand, as we said, at least in the low transfusion needs, it's very difficult. I would like to go back to the Matterhorn study that we discussed earlier. And, you know, it could be the case. I want to say that people did it, but it is possible, you know, to take such a patient who needs 1 unit of blood per month, or 1 unit or 2 units of blood per 8 weeks, to define him as transfusion dependent, put him in the study, and then, because the hemoglobin is 8 or 8.5, you tell the patient you don't need blood anymore, and the patient all of a sudden, quote unquote, becomes transfusion independent, and nothing practically happened to the patient. And we are clinicians, we know that this can happen. So I think one of the discussions, and I think this is our task, either in the hub or as the MDS community, and maybe to convince the regulators as well, what is a good endpoint? I understand, I believe that quality of life is an important endpoint, but there is a great variability and difficult to define it and to measure.
Yeah.
Transfusion needs make sense, but as we said, it is very difficult, at least if we limit to the low transfusion burden. Hemoglobin appears to be more objective. I know the problems, but I think this should be the point. I believe hemoglobin, but I would like to hear others.
The problem is that you are completely right. First of all, in this study, transfusion independence was measured in periods of 8 weeks. I'm a member of this, the update of the response criteria in both the low risk and high risk. I have tried to convince the authors to extend the period of the let's say the definition of transfusion dependence. So in the EU MDS registry, we used 6 month intervals. And so, and the dose density is a very clear measure, because you measure over time as long as the patient is taking transfusions, even one transfusion at 8 weeks. So, and we showed that even at that definition, that density, the impact is already enormous on progression-free survival. So the point is, I think, first of all, you have to have a long period on the assessment of the transfusions. So if you use shorter periods, then it's meaningless, as you mentioned, and Mikkael also. So that's one point, and the other point is that you have to look at not only at the transfusion dependence, but also at the intensity of the transfusion dependence. And hemoglobin is very difficult, because in transfusion, in patients who receive transfusions, hemoglobin levels they fluctuate over time. So it depends very much on the time point when you measure the hemoglobin. So that's also a difficult measure. But maybe others have other opinions.
If I could jump in real quickly. So I was the senior author on this study, which is, of course, why it has the acronym TWiTR. And we did this because there's a bit of schadenfreude with the FDA and how they like to trumpet the fact that they're willing to approve drugs based on quality of life endpoints. Yet when they do, they always have ordinal data that accompanies those quality of life endpoints. So, for example, with the approval of gemcitabine for pancreatic cancer, it wasn't the improvement of quality of life, it was the measure of use of opioids that led to the approval. With ruxolitinib for myeloproliferative neoplasms, sure, there was an improvement in a quality of life instrument, but there was also rigorously objective shrinkage of the spleen, right? So they always have some kind of solid clinical data they can hang their hat on that accompanies their quality of life. And then they'll say, well, it's the totality of data that led us to the approval of this drug, not one isolated data point. But look, we approve these drugs based on quality of life. So we developed the TWiTR analysis because it kind of does the same thing, right? It basically uses objective data in transfusion reliance or dependence and freedom from progression to define a period of time that we would hope would then be an interim marker of a clinically meaningful benefit like overall survival that the FDA could then use to approve drugs in both lower and higher risk MDS. Well, you know, the purpose of presenting this and of publishing this, and we say it really clearly in the letter, is that it's a proof of concept. So the next stage is then to try to validate it in other settings and see whether or not it works. But I really agree with both of you. It's a combination of trying to pull together objective data that regulatory bodies will accept, and also gets towards transfusion density, right? It's this concept, particularly in higher risk MDS patients, where we know they're getting better, we know they're feeling better and having a better quality of life, but we're not able to measure it with instruments like the EORTC QLQC30 because it isn't a good reflection of improvement in MDS patients.
Yeah, I fully agree with you, and so that's why I propose to focus on low risk MDS because we have longer periods, so it will be more. The data will be more reliable and more convincing also for the FDA. So that's what you also mentioned in the discussion of that letter. So we will do it in the next couple of months. So you will see it one day or another.
But I'm curious to hear what Dr. Buckstein has to say, since she's the macher when it comes to quality of life.
Well, I wouldn't say I'm the macher, but you know, I look forward to reading this abstract, this letter. So it's kind of an interesting analysis. I have to confess, I didn't completely understand the figure that you showed with the 3 colors. So I think I'll have to take a bigger dive into that. But, you know, fundamentally, I think as clinicians, we feel that the achievement of transfusion independence is associated, you know, with that lack of disease progression. Although I would argue, you know, just stepping back, if somebody has gone on AZA and they became transfusion independent, but their blasts went from 4 to 8%, but they don't feel it. Their counts are the same, but their bone marrow showed that their, you know, that their disease is progressing, yet they became transfusion independent. I still think the patient may feel better, even though objectively they are progressing. So it doesn't necessarily have to just be one, you know, a composite endpoint with 2 benefits seen at the same time for the patient to feel better. But at the same time, I'll throw out, you know, that the Medalist study didn't show an improvement in quality of life, despite the fact that, and even when they restricted it to responding patients, you know, who ostensibly had a reduction in their transfusion needs, had reduction in their transfusion density, and still we didn't see improvement in quality of life. Now, it may be the way it was analyzed and or those stringent criteria, like how many reach that, you know, minimal clinical important difference that I always have fundamental problem with. I kind of like the figures where they show direction of improvement or decrease or stayed the same. I like those kinds of figures where you get a better sense of the overall flavor and movement and quality of life, as opposed to this percentage improved and this percentage didn't improve, using this, you know, objective cut point of 10 points for the QLQC30, for example. But I'd also want to point out that we've done a few analyses. We haven't published them yet. It's just kind of you know, being looked at from the NDS registry. We have loads of data. And we actually plotted the quality of life scores in patients for whom we had, you know, quality of life measured, because like you, we do it every 6 months, Theo, in the transfusion dependent and transfusion independent stage. So we looked at the patients who started TD, for whom we had a quality of life assessment, and then for whom they achieved TI, presumably on some kind of therapy, and for whom we had a quality of life assessment at the time. And we defined TD and TI using as sort of no transfusions for 16 weeks, basically. And when you look at the curves, and depressingly, we have more patients starting off TI and becoming TD than we have TD becoming TI in our figure. But nevertheless, the curves definitely show the direction that you would think. The overall flavor of the curves is improvement in symptom and function domains in those that become TI, and a decline in those that become TD. But the speed, the steepness of the curve in becoming from TI to TD is actually higher. So it speaks to the idea that we do want to try to maintain transfusion-free survival as long as possible. So in patients that are transfusion independent, maintenance of transfusion-free survival is so critical, because they do have such a dramatic decline in their symptom and function scores when they become TD.
But this is not a surprise because the disappearance of the iron overload or the iron toxicity will be slower than the transfusion independence.
It raises that, exactly, or there's other function. And the other point I would want to make is, we've done univariate and multivariate analysis looking at the predictors of the quality of life scores that we have. And though transfusion dependence does feature prominently for sure in all univariate analysis, and hemoglobin as cofactors in the determination of these scores that patients are reporting, frailty and disability are continuously present as risk factors. And so it means that sometimes, even if we render someone transfusion independent, but they have other things going on, they have a lot of comorbid disease that are symptomatic, or they are frail, we may not see the improvement in the quality of life scores that we seek. So we're going to have to control for that. And that's sort of the message that I'm going to transmit to the FDA when we present this next week, is that it's another reason for measuring it in our clinical trials, so that we can better interpret the quality of life scores according to these degrees of, disability or frailty, because we may only see improvements in those that are not significantly, frail or had disabilities.
Rena, are you going to present some of the NHLBI data that just came out in Blood Advances?
Yeah, I am. Actually, I wasn't sure I was going to present it because I didn't see that it was. I was reviewer on the paper, and I was like waiting for it to come out so that I could show it, because I wasn't sure if I was allowed to until it came out. Because it's technically. Yeah, so I just saw that it came out, so yes, I am planning to show it. Yes.
Theo, I have a question, maybe a comment, but the data you showed us published in the Hematologica was pevonedistat plus azacitidine trial, right?
Mm-hmm.
So in that trial, higher risk patients were treated with azacitidine plus minus pevo. That means doctors should use azacitidine as much as possible, because all we know that azacitidine is important drug for high-risk MDS. But also at the same time, azacitidine makes cytopenia strongly. So if you use full dose of azacitidine, that makes more cytopenia. That is shown comparing the 5-day and 7-day trial of azacitidine. The cytopenia was stronger in 7 days group. But at the end of the day, leukemia-free survival time is longer for 7 days. But that is not easily understood for patients in a short term. In a short term, they like no transfusion. But in a long way, leukemia-free time is more important for physicians and finally patients and families. So as you said, the measure of quality of life, transfusion dependence time, it should be different between lower risk MDS and higher risk MDS. And also the side effects of drug itself has strong impact on the quality of life or how patients feel, probably including the price of the drug itself.
You are completely right, because that's why I propose to repeat these studies, first of all, in larger populations with a longer follow-up, but also in lower risk because they are not treated with cytotoxic drugs. So the cytotoxicity of azacitidine in both arms are playing a major role in this study, and that's right. So we have to do the other studies. And everyone, but also the authors of the study were aware of that.
No, I agree. I think there's going to be differences between lower and higher risk disease depending on the toxicity associated with the agent being tested. I mean, certainly hypomethylating agents are being tested in lower risk trials as well. You know, we have an oral AZA study opening again, and there's planned decitabine studies in lower risk disease or ongoing. So there may still be toxicities associated with them in the lower risk patients too. So they may impact on the quality of life scores. So the degree of the confounding effects of the drug are going to impact, no question.
Thank you.
Theo, just to add to the Rena's comment earlier, I would like to share with you a study that we finished in our group, presented in ASH a couple of years ago, and now the paper is ready for submission. And we learned all patients were low-risk MDS, and two lessons that we learned from that study. Number one, again, there is a steep decline in quality of life between hemoglobin 9 and 8. So exactly, it's not linear as Rena suggested or said. And the second point, we went back and assessed quality of life 1 year after. The first point was at presentation, and then 1 year after. And out of the 120 or something like these patients, about 64, 65 patients had again quality of life questionnaire 1 year later. And it became clear that even in those patients whose hemoglobin rises due to treatment, quality of life not necessarily is improved, suggesting that by increasing hemoglobin, not necessarily quality of life improves, and maybe other factors, and we discussed it also in the podcast, Rena, maybe other factors in addition to hemoglobin are influencing quality of life.